Hello, and welcome to this webinar on safety at the heart of Affera, mapping and ablation systems, real-world cases, and system comparisons. It is my pleasure to be joined by Dr. Miguel Valderrábano, a cardiac electrophysiologist of Houston Methodist Hospital and someone who I think needs no introduction to most watching this now. Reminder, today's webinar is supported by Medtronic. To start with, let's briefly recap our learning objectives for today. Understand the clinical and real-world safety data of the Affera mapping and ablation system in Sphere 9 catheter. Discuss clinicians' experience with workflow, safety, and efficacy with the Affera mapping and ablation system in Sphere 9 catheter. So without further ado, at this point, I'd like to hand it off to Dr. Valderrábano for his presentation. Following this, we'll have a discussion regarding exploring the key themes. So please stay tuned.
Thank you very much. As you've heard, my name is Miguel Valderrábano. I've been using this system in our hospital for the past almost 11 months. And I will be sharing with you some of the general data regarding the safety of the Affera system, in general safety of electroporation, and briefly dwell into our experience so far. So when we talk about electroporation, we need to understand it as an ablative strategy that entails creating a voltage across the cell membrane of the targeted cells that leads to electroporation of the membrane, and that leads to cellular death. When you put this voltage across the tissue, depending on the voltage, amplitude, and the pulse duration, you may get reversible electroporation, which is a technique used routinely in molecular and cellular biology to facilitate the entrance of DNA in cells. That's been used for a long time. If the electroporation does not recover, that leads to irreversible electroporation. And if you have too much amplitude or too long a pulse duration, you engage in thermal tissue damage, similar or no different to what we used with radio frequency. So the idea here is to capitalize on a range of parameters that will lead to non-thermal damage and irreversible electroporation to achieve tissue ablation. The promise of PFA, therefore, is to achieve safety, ablating preferentially cardiac tissue. And this is something that has been at the basis of pulse field ablation from the very beginning. The idea that myocardium is inherently more sensitive to electroporation than other tissues. And that probably is based on the fact that the myocardium is already polarized, and therefore the membrane is more prone to build up a voltage above the threshold for poration. Therefore, if the tissue in the myocardium is more sensitive than other tissue, then you will expect ablation to be focused on myocardium, preserving the neighboring nerves and preserving the arteries and vascular structures. Ideally, because you create no inflammation, there will be no shrinkage of the tissue as it heals. And this is what would eliminate the risk of pulmonary vein stenosis. This is without obviously compromising the efficacy, because depending on the pulse parameters, electroporation or PFA can create lesions that are contiguous and transmural in the shape of your electrical field. And because of the catheter designs, you can deliver ablative fields over a large extension of tissue, making it easy to achieve fast PV isolation and ablation of large extents of or surfaces of tissue. So that's the promise. Let's see how true that is. If you compare tissues that have been subjected to radio frequency with tissues that have been subjected to pulse field ablation, you will see that in the ablative tissue, you will have hemorrhage inside the tissue, thrombosis in the vascular structure, and disruption of the tissue, that as opposed to more homogeneous fibrosis and normal patent vessels when you deliver PFA. Radiofrequency leads to an acute shrinkage of the vessel wall and remodeled arterioles, interstitial hemorrhage, whereas PFA does not do that, does not alter arterioles, and we'll talk about spasm in a bit. And the end result is a different tissue damage altogether with a different healing. Whereas radiofrequency will give you fibrosis and lipogranulomatous inflammation, tissue subjected to PFA will have normal epicardial fat. So what is the story of spasm? As you deliver a field across tissues, the smooth muscles can be also subject to electroporation. And although it hasn't been really validated at the molecular or cellular level, it's just straightforward to think that as you deliver a field in smooth muscle cells, you may lead to contraction of the smooth muscle cells, and that is expressed, so that shows up as spasm in the coronary arteries. This was first noticed when delivering PFA with a large platform footprint catheter close to the circumflex arteries, but also when delivering PFA in the cavo tricuspid isthmus close to the right coronary artery. It definitely puts a little bit of a reality check on the promise of PFA, but it's one that can be managed clinically. What has been shown is that when you deliver radio frequency in close to an artery, you can create serious damage that can be permanent. When you deliver PFA next to the artery, you get to acute spasm. There's some degree of narrowing, so it's not entirely benign. There's some degree of narrowing of the coronary arteries that can be seen up to 3 months later, as demonstrated by optical coherence tomography in this study, but also in animal models where it's been shown to have some intimal hyperplasia after the spasm has resolved. Acutely, let me just stop here. Acutely, the spasm is typically managed with nitroglycerin, and in all cases, reported nitroglycerin leads to a correction of the spasm. So what is the Affera system? The Affera system entails two pieces of equipment. One is the catheter, obviously, the Sphere 9 catheter that we'll discuss in a bit, as well as the generator and the mapping system. The generator, that is basically two generators in one that delivers radio frequency and one that delivers pulse field ablation. The catheter is quite complex and yet very simple to manage. It contains the lattice tip, which is a sphere made of nitinol that has 9 miniaturized surface electrodes with integrated thermocouples. The interesting thing is that you can get electrical information and electrograms and temperature information from each of these 9 electrodes and thermocouples independent from one another. And yet, when you deliver radio frequency or PFA, the entire sphere is the active electrode. So this is extremely helpful because you can get very, very useful mapping information from electrograms that are obtained as a regional unipolar. The reference electrode is inside the sphere, and the active electrode is outside in each of these 9. So you can get good information for mapping. Good temperature information that I will show you. It's useful for guiding radio frequency, and a very large footprint for ablation. The catheter is an 8 French catheter. It's the same catheter for mapping and for ablation, so it's a single transseptal that allows optimized workflow. It's bidirectional, same handle or very similar handle that we're used to. And it feels immediately at ease in our hands because it's no different to any other catheter, and we use the same sheaths that we would use with any other catheter we used to. The software is its own development and requires a little bit of time to get you familiar with it. It displays the sensor globe, a schematic of the sphere catheter showing the location of the 9 mapping electrodes that provide real-time local impedance measurements as a guide to contact. These electrode location, because they are the same location as the thermocouples, they're used to temperature monitoring during RF and PF delivery. And it gives you a signature of the PF delivery to the tissue. In the mapping, it creates automatic tags. If you complete the delivery without moving, you will get an automatic tag. And it has a built-in tag connection algorithm that informs you when you're delivering a linear lesion set as to whether your consecutive lesions are adjacent to one another. And you can configure the distance that you're willing to tolerate. This is kind of how the software works as you move around with the catheter. The local impedance data is showing you when you're touching the tissue. You see the location of the thermocouples swell up as they touch the tissue. So you know that that particular thermocouple or electrode is touching the tissue and is in contact. Because with PFA, contact is important, but force is not so important. It's really, it really eliminates the need for contact force sensing. Anyway, as you move around, you will see that the electrodes swell up. As you make contact, the more electrodes swell up, more electrodes are touching. And you will see that immediately corresponding to the recording of higher amplitude signals. Okay, when you're, the sensor globe alert you when you're about to deliver radio frequency, it'll warm, or PFA, it'll show you the temperature that each of the thermocouples is achieving. That gives you an idea of how much the tissue is getting heated. And for PFA, you expect some minor increase of temperature as the PFA pulses are being delivered as an indication of adequate tissue reach. The workflow is very similar. It requires minor adaptation to what we've done for a long time. We typically obtain 3 femoral vein axes in one side. We can work as we have for years in a no fluoroscopy protocol, where a lot of the imaging initially is based on ice to guide the transeptal puncture. Even though we don't typically create a map of the right atrium and the coronary sinus, and the current software cannot display the location of not any other electrodes. So we typically cannulate the CS based on intracardiac echo mapping, which can be a bit challenging sometimes. But once we create the transeptal puncture, we make a left atrial map with the Affera catheter. It's very easy to see on ice, and you don't really need to, but it does help you in the initial portions of the mapping to see it on ice. We create a full left atrial map, and then we deliver pulmonary vein isolation and posterior wall isolation as desired. Over the past, like I said, 10 months, we've done more than 800 cases at Houston Methodist. We've had first pass isolation in all but one pulmonary vein pair. In one pulmonary vein pair, we had reconnection intraposteriorly that was basically reinforced. In both cases, were reinforced with additional lesions. We have 0 effusions. We had 1 case of ventricular fibrillation induction during PFA in the mitral isthmus. So our routine case looks like this. We do an initial map. We plan the lesion set. This is an interesting evolution of at least my lesion sets, that I started doing 2 circles like most people, but then when the dilemma between PVI and posterior wall was an active controversy, I decided to just create a single circle around the right pulmonary veins and add that with lesions completing the roof, the ridge, and the inferior posterior line to achieve isolation of the left-sided veins. With this catheter, this kind of ambitious lesion set can be achieved, like I said, more than 99% success first pass isolation. In general, procedure times are around less than 1 hour, total atrial time about half an hour, and we add the CTI lesion that usually takes about 3 minutes, 4 or 5 applications along the CTI. The one thing that we have learned that is an interesting safety and efficacy consideration is the fact that the ablation can be so effective that it adds a level of accountability or responsibility on the operator. Let me show you what I mean in one example. So this is a case of a patient with a previous ablation of AFib, pulmonary veins were done, the posterior wall was done. The patient had several cardiac surgeries and presented with this right atrial flutter that was, map, with a beautiful, nice map along a potential scar here from an incision from a previous surgery. So this was ablated doing a line from the core of the reentry to the tricuspid annulus. No big deal. And then this patient had a previous CTI line, and during induction of AFib, he had complex potentials along the crista. Everything was very quiet in the left side. So we added this lesion set. We had an SVC to IVC lesion set. Then we completed the line that we had done in the lateral right atrium to connect with this vertical line. You think that's pretty innocent. We also had done the CTI line. When we were testing the CTI line for block pacing the coronary sinus, then it became obvious that we had isolated the entire right lower quadrant of this right atrium, because this line was effective at creating bidirectional block. This line was effective, and the CTI line was effective. So it turns out that sinus node activation cannot propagate into this area. Now, this probably has no clinical relevance, but it alerts the operator that, not like with radio frequency, that you would do this line over and over, and it becomes really hard to get bidirectional block across this line, at least on a first ablation attempt. And with Affera, this is something that you can expect routinely. So what is the evidence of the use of this catheter in clinical settings? This is the history of the Sphere 9 catheter over the past 6 years. Initial preclinical models entailed the use only of radiofrequency with this catheter. And it showed the lesion dimension, safety, efficacy, and durability. This was moved on from right atrial and thigh model to the pulmonary veins, again in a preclinical model. Then in 2020, when the PFA term and the word of PFA was becoming a hype in the field, basically Affera started developing the PFA waveforms, and first published in 2020. The first in human RF trial was in 2020 as well. And in 2020 to 2023, the first hybrid RF and PF first in human trial was published, showing safety and effectiveness of PFA and in persistent atrial fibrillation. The impact of repetition of PFA, the impact of some optimization of the waveform was further implemented. And then in 2024, the Sphere persistent AFib pivotal IDE trial was published, showing safety, effectiveness, and the learning curve of persistent atrial fibrillation. And from then on, we're collecting real-world clinical data. So what kind of lesions do we create? On the top here, we're showing the radiofrequency lesion size. We're using the Sphere 9 catheter in terms of the diameter, and compared to the same lesion size using pulse field ablation. The pulse field ablation protocol requires 4 seconds, and the radiofrequency ablation protocol requires 5 seconds. The lesion diameter is 17 and 18 millimeters, respectively. This is quite big. This is bigger than much bigger than you can achieve with conventional ablation catheters with radiofrequency. The depth is very similar, about 5 millimeters deep. So all in all, this makes it really ideal for atrial fibrillation. A little bit of more detail as to the first in human results when the Sphere RFPF catheter was tested. It was a non-randomized trial in Czechia and Lithuania. 70 paroxysmal AFib patients, 108 persistent AFib patients. In this study, different pulse parameters were tested. The idea here was to establish the safety and the efficacy. Safety endpoint, 0.6% of patients reported primary safety event. I will go into detail as to what those were, but no PV stenosis, no obvious coronary artery spasm, no atrioesophageal fistula or phrenic nerve injury. And the efficacy endpoint, which was pulmonary vein isolation, was achieved in 100%. You can see how also the durability of PV isolation, depending on the optimization of the protocol, the pulse waveform. But with the third iteration, the durability of PVI after remap was 97% on a per vein basis, translating to 90% of the patients with all veins durably isolated. The durability of the left atrial roof, the mitral isthmus, and the CTI lines were less uniform because of the complexity of the anatomy there. But you can see how it's 82% for LA roof, 68% for mitral isthmus, and 87% for CTI. This is a detail of the safety endpoints in this study. Basically, one hospitalization, which was basically due to an inflammatory pericardial effusion that did not require any catheter or surgical intervention and responded to anti-inflammatory drugs. This is something that we're used to seeing in any AFib ablation. How safely is this catheter for the esophagus? There was study where the patients underwent post-procedure esophagogastroduodenoscopy. There were 3 instances of asymptomatic minor mucosal injury related to inadvertent posterior heating with radiofrequency ablation, not with PFA. PFA had no lesions whatsoever. So this is important to know. We've been interested in how much heating does actually PFA lead to into the esophagus. And we did a study, a very quick study, shortly after we had access to the system, where we looked at luminal esophageal temperature rises with pulse field ablation, and we looked at 3 platforms. We put the CERCA probe in the esophagus and delivered a PVI lesion set with Affera, with Pulse Select, and with FARAPulse. This was published back in May. And we showed that the temperature rises were minimal. The highest temperature rises were indeed seen with the Affera catheter compared to Pulse Select and FARAPulse, but they were pretty much manageable. The highest was 38.3, an average of 37 degrees, as you can see in these box plots. There were minimal post-ablation temperature rises. This is something that we were used to with radiofrequency ablation, where we would deliver RF, we'll see the temperature go up and then stop RF, and the temperature will keep going and going and going. This doesn't happen much with any of the platforms. And the rate of rise of the temperature, the DTDT, was relatively slow and something that you could manage. So after this, we stopped measuring temperatures when using this catheter. So then the largest study looking at the Sphere catheter in persistent AFib was the Sphere per AF pivotal ID study published in Nature Medicine in 2024. Randomized clinical trial running 23 sites, taking patients with persistent atrial fibrillation. There were 37 enrolling patients and 212 investigational. The patients were randomized to either PV isolation with the Sphere 9 catheter, using RF in the roof and anterior wall versus and PF in the posterior wall, versus the thermocool ablation catheter using pulmonary vein isolation. You can see here the trial met criteria for non-inferiority. And you could argue the results were better with the Sphere 9, 73% freedom from recurrence at 1 year versus 65%. That's a p-value that's very significant for non-inferiority. The adverse events were 3 in the investigational arm versus 2 in the control arm. And the procedure was quicker, shorter application time, transpire ablation time, and skin-to-skin procedural time were quicker. What were the safety endpoints? As I showed here, basically hospitalization due to cardiovascular or pulmonary adverse events, excluding hospitalization due to arrhythmia recurrence. And these were pulmonary edema due to hypertensive emergency, exacerbation of COPD, and hemoptysis with RNA evidence, so bleeding. So these are pretty much inconsequential stuff that happens. It happened equally in both arms. But the important thing is there was no phrenic nerve paralysis, no strokes, no gastroparesis, no severe pericarditis, no tamponades, no esophageal fistulas. So all the stuff that we typically are concerned about in AFib ablation, all these potential complications that for most of us have limited the range of patients that we subject to AFib ablation were eliminated. So to conclude, uh, the PFA safety is impacted by several design features, including waveform, catheter tip configuration, and workflow integration. Obviously, you want to have a catheter that, yes, you know it delivers the lesions that we are aiming to deliver, but it also incorporates well, or it blends well with your procedural workflow. The dual energy sphere 9 catheter has seamless integration with the Affera mapping and the ablation system, and allows for safe and effective AFib ablation. In my experience using this system is in line with the results of large pivotal studies. A few lessons learned, I think, when you start using this catheter for the non-standard lesion sets, as we are talking about beyond pulmonary vein isolation, if you start doing lines, it's great. It can deliver those lines, but you have to be cognizant of the fact that now you're accountable for those lines, and you can expect block when you deliver a line and you do it thoroughly. So with great power comes great responsibility. The catheter is incredibly powerful and easy to use, and for all of us in our center, we have this joke that once you use it, you don't want to use anything else. It has made ablation routinely a 45 to 1 hour minute to 1 hour procedure, and including patients that you would think in the past that would not have been candidates for the ablation because of their higher risk. One thing that I haven't mentioned that is really not really discussed in clinical trials is the patient experience. The patient experience with PFA is much better than with radiofrequency. The patients, I remember doing AFib ablation with radiofrequency and doing extremely complex and aggressive lesion sets. The patient would be miserable for a couple of weeks. With PFA, and specifically with Sphere 9, many patients can undergo aggressive ablation plans and wake up as if nothing happened. So I'll stop there, and I'll be happy to participate in the discussion.
Miguel, thank you. That was a great review of your experience at your hospital with Sphere 9 and the Affera mapping system. I think we'll get now to some questions from our audience. First, can you discuss the implications of this single transeptal no catheter exchange workflow and how you feel that benefits both patient safety, efficacy, efficiency, and all the meaningful endpoints that we care about?
The first, just doing it once, so it saves you time. But more importantly, the idea that you don't have to engage into catheter exchange. So years ago, we moved from the double transeptal to the single transeptal, and that was a matter of efficiency in the procedure and minimizing procedure exchanges. We all trained doing PV isolation with a mapping catheter in the pulmonary vein, and you would ablate proximal to that catheter until the signals went away. With more reliable ablation tools, with contact force, irrigated ablation, busy tags, some quality control of our lesion set, we learned to become much more effective at reliably achieving PV isolation with a single pass. And we did not need the real-time mapping or the real-time signals from the veins as we were delivering that. The problem was that you would do a lesion set, and then you would want to map if there's a less than complete ablation. So you have to put a catheter, remove your ablation catheter from the transeptal sheath, put a mapping catheter, map the propagation, and then every time you do an exchange, there's an opportunity for emboli. No matter how careful you are, the more exchanges you do, the more likely you are to get in trouble. particularly when you're using complex sheaths. With the Sphere 9, you use a regular deflectable sheath is what I normally use. And probably you could use a non-deflectable sheath just the same. And you never have to come out, you never have to pull this Sphere 9 catheter until you're done. So you may do your circular lesion set, you then advance the catheter, validate that you have no electrograms in the pulmonary vein antrum. And if you do, you use the same catheter to map the ablation line to figure out where the gap may be, and then apply. So all becomes a smooth procedure workflow. So it becomes really completely streamlined to map and ablate when you don't have to pull the catheter out. Say you're ablating a persistent AFib, you do your PVI, posterior wall, and then the patient goes into a flutter. Yeah, okay, let's map. I don't need to change the catheters to do that map. And I get, you will hear, this is kind of off the script, but you will hear people say, well, a Sphere 9 is not a great catheter for mapping. The signal quality is plenty good. The area that you're mapping at any given time is obviously limited to the 9 mm diameter, but you can get great maps with this catheter if you're careful as you annotate, as you get the points and annotate them.
Yeah, I would second that, Miguel. I mean, as a high density mapping catheter, it is certainly functional, but what we are looking for is that intermediate footprint ablation platform. Now, last question, because I think we'll have to wrap it up based on time, but if we look at simultaneous RF PFA ablation, do you see that as a therapeutic modality, as something that's here to stay? And would you, to that end, maybe comment as we all think about how PFA is revolutionizing our practice patterns with AFib management?
If your practice entails redos, persistent AFib, long-standing persistent AFib, large atria, scarred atria, structural heart disease, mitral valve replacements, the complex story, then you need the flexibility that this catheter gives you. And to be true, when I do paroxysmal AFib ablations, right now I'm doing this wide area PV antral isolation that takes the posterior wall too, and it takes the same time because one big circle with Affera around the pulmonary veins, even wide enough that the vertical line is in the middle of the posterior wall and it's shared by the other PV antrum, it doesn't take any longer than a circle more ostial. And the confidence that you get knowing that in the vast majority of cases, you're going to get first pass isolation. I don't really worry that I don't need a single shot. That's what I'm getting at. I don't need a single shot. I think the flexibility of then being able to map other areas, and this we get into unproven stuff, but other areas, be it complex potentials or rotors, whatever you want to call it, spatial temporal dispersion, other approaches. Whenever you deviate from a standard PVI, this catheter, this kind of smaller footprint, allows you the flexibility to do whatever you want with the knowledge or the peace of mind that you're going to get the job done.
Yeah, I would agree with that. I think the mantra for my practice has become flexibility. And it seems like the intermediate footprint with the combined RF-PF energy and a high density mapping catheter, therapeutic catheter all in one, that offers the flexibility. To get back to our prior question, air is our enemy. Sheath exchanges can only increase complications. Left atrial dwell time can only increase complications. We're adding safety onto it. So real quick, Miguel, I'm going to ask for a hot take. Last question. In your clinical experience, what is the learning curve for this system?
2 cases. If you're experienced in pulmonary vein isolation, this requires 2 cases. just minimal stuff, like the preparation of the Sphere 9 before you put it in.
You and I did not talk about this question before, but I would second that as a primary RF operator prior to PFA coming in. I was going to say 2 cases just to get used to the user interface and the prepping of the catheter. So you and I are in complete alignment on that. So at this point, I would like to thank everyone for joining us tonight. Once again, this is David Wilson. I'm the Chief of Electrophysiology at University of South Florida and Tampa General Hospital. Thank you, Dr. Miguel Valderrábano from Houston Methodist, for your insights this evening. And I'd like to remind everyone that tonight's webinar has been presented and supported by Medtronic. Thank you, everyone, for joining. Have a great night.